Good evening, ladies and gentlemen. I welcome you all again to this ILD webinar series organized by the ICS. And I'm very thankful to Dr. Sandeep Salvi, the President ICS, Amita and Raja, the Chair TI and Secretary ICS, for the opportunity for all of us, as well as all the people who have logged in for this very interesting, discussion on cystic ILDs, the best approach. We still don't know whether we have reached the best yet as far as treatment is concerned, but yes, we have made some strides as far as diagnosing and differentiating various ILDs are concerned. When we were studying, it was kind of a very perplexing and intriguing and a very disturbing topic for postgraduates. And, if we get a question, we could be kind of getting stuck up in the exams. We would not know how to answer. There weren't very many, discernible features on radiology, not very many diagnostic algorithms as to how to differentiate one ILD from the other. And of course, as far as treatment goes, it's only in the last few years that we have seen that there is some form of treatment, medical treatment available for these ILDs as well. So today we're going to cover a very, very interesting topic of cystic ILDs, the best approach. And we have an excellent, panel of speakers and 4 panelists who are learned, well, known across the country for their kind of academic, excellence and wonderful speaking abilities. And without wasting much time, I would be very keen to introduce our first speaker, Dr. Khushboo Pilania. Can I have the introductory slide? Dr. Khushboo Pilania is an MD radiology. Her special interest, of course, as we all know, is chest radiography, musculoskeletal radiology, and MRI. She's the founder and consultant radiologist, Eyes and Imaging and Interventions, Noida, consultant radiologist, picture this by Dr. Jankaria, member of the Indian Radiology and Imaging Association, Society of Chest Imaging and Intervention, Joint ILD Guideline Committee, both ICS and NCCP, Musculoskeletal Society of India, International Weight Bearing CT Society, academic affiliate, and Indian Musculoskeletal Oncology Society. She has lots of and many national and international publications to her credit, many national and international conference presentations, book chapters, and guest lectures. And we are happy to welcome you on this panel. I know you are the odd one out. You are the only radiologist among all the pulmonologists who are gathered to kind of, learn everything from you and make a headway into, understanding and treating cystic lung diseases. Over to you, Dr. Khushboo.
Thanks a lot, sir, for that kind introduction. I'm not sure how much justice I will do to this topic, which is definitely intriguing. As you said, it's as yet a large part of it. We've all, learning. We are all still learning to figure out how to differentiate one from the other. But definitely, we've over time developed a kind of an algorithmic approach on how to differentiate one cystic ILD from the other. And that is what I'll be discussing over the next 15 minutes or so. So the entire question when we talk of cystic lung diseases is that there are multiple insults which lead to formation of cysts within the lungs. Now the question is how to differentiate one from the other basis the findings on HRCT, how to triage them and to understand what particular pathology are we dealing with. So in order to be able to do that, we make it a bit simpler by trying to ask ourselves few simple questions. Number one, whether it's a cystic interstitial lung disease, whether you are seeing cysts without any other findings or there are cysts with other findings. So there are a lot of other pathologies like infections which presents with cysts and so on. But there is an entity of cystic interstitial lung diseases where the pathology is the involvement of the lung parenchyma due to a background systemic process. In these cases, when we try to differentiate, the foremost important thing is to look at the lungs beyond the cysts. So we have cysts in the lungs. Is there something else affecting the lung parenchyma or the background lung parenchyma is normal? So when we start with the first question, so when we are looking at cysts within the lungs, it is very important first of all, to be sure that what you are dealing with are true cysts and hence it's a cystic lung disease versus whether they are just, dilation of air spaces due to some other pathologies. How do we call it? Call it a cystic disease or call them true cysts. So the first and foremost thing is that the cysts have well-defined walls. The cysts do not communicate with each other. they usually do not share walls, and they can be subpleural but also random. So this is when you start calling something cystic disease. Because again, I'm stressing that there are a lot of pathologies like honeycomb cysts, bronchiectasis, they all present with holes in the lungs. Not all holes are cysts, and hence not all holes represent cystic interstitial lung disease. So we'll try to look at them one at a time. This is how a cystic lung disease appears. So you have these well-defined cysts with well-defined walls with interspersed normal lung parenchyma. They are not sharing wall, randomly distributed. However, in this, you see a conglomerate of cystic areas. If you try to scroll on your computer up and down, you'll see that they communicate with each other, and hence it is bronchiectasis. Then again in this, you're seeing a lot of holes all over the lungs, but they do not have walls. So when they don't have walls, they are not cysts, these are emphysema. Then you look at these, again, tiny cystic areas. This is traction bronchiectasis because again, they're communicating with each other, and you see the distortion of the surrounding lung parenchyma causing traction dilation of these bronchi. Honeycomb cysts, so these are cysts, but not of the cystic lung disease. Why these are honeycomb cysts? They are all sharing walls with each other. They have architectural distortion. And as I said, that these true cystic lung disease do not share walls with each other. So you need to be, very particular about differentiating a cystic lung disease from honeycombing, because honeycombing is seen with fibrosing interstitial lung disease, the UIP, IPF category, whereas cystic lung disease is altogether a different category. Again, you see these paraseptal cysts. So these again share walls and they are associated with emphysematous changes. So this is how you first differentiate true cysts from the other differential diagnosis, that the other holes in the lung, and you try to call them cysts. Once you're sure that what you're dealing with are true cysts, so it's a cystic lung disease. Now we start characterizing what cystic lung disease is. There are certain cystic lung disease where the background lung parenchyma is absolutely normal. So when you see a large number of cysts in the lungs and the background lung parenchyma is normal, then you think of certain specific cystic lung diseases, which include this list: lymphangioliomyomatosis, Langerhans cell histiocytosis, Berthold-Dube, cystic metastasis, and cysts in Sjogren's or the lymphocytic interstitial pneumonia. How do these appear? So when you have cysts of histiocytosis or Langerhans cell histiocytosis, these patients are usually smokers, apart from the pediatric age group where it is a part of the histiocytosis X disease. They may or may not be associated with nodules. They have an upper lobe predilection. So then when you see such cystic areas all over the lungs with some background nodularity in a smoker with an upper lobe predominance, you know you are dealing with pulmonary Langerhans cell histiocytosis. So you see this typical upper lobe distribution and the CP angle sparing in this cases. Often these cysts can also be larger, leading to pneumothoraces, where you see these loculated pneumothoraces. So this is a pulmonary Langerhans cell histiocytosis cyst in a smoker with upper lobe distribution. When you see cysts in a woman, non-smoker, and with a background normal lung parenchyma, someone who's presented with repeated pneumothoraces, then in these cases, the topmost diagnosis is lymphangioliomyomatosis. So when you see such cysts with a background rather normal lung parenchyma, you know you are dealing with lymphangioliomyomatosis. Another example where you see these scattered cysts, you see this thin pneumothorax around here, and the background lung parenchyma is pretty much normal. The bases were more severely involved with these larger cysts and the pneumothorax. So this is a lymphangioliomyomatosis. Now the question is, what if it's a 45-year-old man, non-smoker, who comes to you with repeated pneumothoraces and you see such lungs? So since it's a non-smoker, Langerhans cell histiocytosis is out of question, 45-year-old non-smoker. Again, in a man, the diagnosis of LAM cannot be made unless the man is known to have tuberous sclerosis. So now what else are we looking at? And we are seeing these sequential CT scans from 2009 till 2015, where we see that these cysts are rather, they have remained rather stable. And this patient had presented with pneumothoracis. So what is the most likely diagnosis? Is it lymphangioliomyomatosis? Is it Langerhans cell histiocytosis? Is it Berthold-Dubé, or is it a cystic metastasis? So obviously, when you see such cysts, again, I'm stressing on the fact that it's a non-smoker man, you should be thinking of Berthold-Dubé syndrome as your diagnosis, and you should be getting an FLCN gene mutation and looking for skin lesions in these patients. So as I said, if it's a woman with cyst, we think of LAM. It's a male smoker or even a female smoker. And if you also see some nodules, then LCH is the topmost diagnosis, but neither, then please think of Berthold-Dubé, which is also rather common. So as I said, in these cases, we need to get the FLCN gene mutation. Now we talk about interstitial lung diseases with some abnormality in the background. So like, for example, we talked about PLCH, where you see nodules. Again, with amyloidosis, you may see nodules, and sarcoidosis also, you may see nodules. So you see cysts with some background abnormality, which is predominantly nodular, then these three are our top differentials. When you see cysts with background ground glass attenuation, then this is the list of differential that you should be thinking of. So the light chain deposition disease, the lymphocytic interstitial pneumonia, hypersensitivity pneumonitis, desquamative interstitial pneumonia, healing insults and cryptogenic organizing pneumonia, and pneumocystic Jerevicai infection. So these are the topmost differentials that you should be thinking of when you see a lot of cysts and a background abnormal lung. So like, for example, you see cysts and you see a diffuse ground glass haze all over the lung. She's a 59-year-old, known case of Sjogren's. The diagnosis is straightforward. It is lymphocytic interstitial pneumonia. If it was an immunocompromised patient, then you see cysts with such ground glass, then pneumocystic Jerevicai is the first thought that should come to your mind. So let's see a couple of cases. So this is a 45-year-old smoker under evaluation for shortness of breath. What do we see? We see few scattered cysts. We see some confluent nodularity, which has a rather centrilobular distribution in both lungs. So what is the diagnosis? A smoker with nodularity and cysts all together. So it becomes a Langerhans cell histiocytosis. So again, a companion case, a 52-year-old smoker. Again, we are seeing some holes all over the lung. We go down, we are still seeing them, and some diffuse, ill-defined ground glass attenuation. So the first question in this case is, are these holes cysts? That's a very important thing that we need to address. So when you look at them, you realize that they do not have walls. So when they don't have walls, these are not cysts, because obviously smokers are also prone to have emphysema. These are all emphysematous areas, and we are seeing a background sheet-like ground glass attenuation. So it is a desquamative interstitial pneumonia in a patient with emphysema. So this should not be confused with a cystic lung disease, and this should not be confused with a Langerhans cell histiocytosis, because the patient is a smoker. Now, this is a straightforward 48 years old, known to have Sjogren's. So you see these ill-defined ground glass attenuations with these interspersed cystic areas. So this is a typical lymphocytic interstitial pneumonia. This either occurs in a known Sjogren's patient or a patient with HIV, or if the patient is immunocompromised. If the patient is immunocompromised or has HIV, then again a close differential is pneumocystic Jerevicai pneumonia. So these are the few questions that we did address to while we talked about cystic lung disease. The first and foremost is if it is a cystic interstitial lung disease. So first and foremost thing that you ask yourself is, are these true cysts? Or is it emphysema, or is it honeycombing, or is it bronchiectasis? Because emphysema, honeycombing, bronchiectasis does not mean cystic interstitial lung disease. So you talk about, first try to differentiate whether what you're looking at are true cysts. If they are true cysts, there are two very simple questions that we ask ourselves. Is the background lung normal or abnormal? If the background lung is normal, there are limited differential diagnosis. In a woman, it becomes LAM. In a smoker, think of LCH, otherwise also think of Berthold-Dubé syndrome. If you are seeing nodularity associated with cysts, think of amyloidosis, Langerhans cell histiocytosis, and sarcoidosis. The bullous sarcoid sometimes presents with as a cystic lung disease. If you are seeing a lot of GGO along with the cyst, then you think of lymphocytic interstitial pneumonia if the patient is a known Sjogren's or has HIV or is immunocompromised. If there is significant air trapping associated, think of hypersensitivity pneumonitis. The patient is a smoker with associated emphysema, think of desquamative interstitial pneumonia. So this is a simple algorithmic approach towards a cystic lung disease. And that's how we look at it. We do come across some random or aberrant cases always, but I mean, approximately 85 to 90% of the dilemma is sorted when we follow this approach. So that's from my side. Thanks a lot. If there are any questions, I'll be happy to take.
Thank you, Dr. Khushboo, for a very elaborate discussion on cystic lung diseases. And I must say, the CTs that you got were kind of, most of them were pathognomonic, and they were kind of staring, the diagnosis was staring on the face, but most of the times it is somewhat a mixed of a couple of things which come to your mind, but it is difficult for us to differentiate one from the other. And you would have a list of differentials rather than a specific diagnosis. Of course, all the ancillary features, sex of the patient, smoking or no smoking history, any association with kind of immunocompromised status or autoimmune status, any skin lesions, anything in the abdomen, anything in the kidney, which might be able to kind of help us differentiate one from the other. But I must say, a wonderful effort from you and an excellent presentation. And of course, I know you would not be able to stay with us till the end of the talk. I just have 3 or 4 questions in my mind. I know it is going to be a repetition of sorts, but just to clarify and try to give the audience a clearer picture, just a repetition and a reiteration of certain things which you have covered, I'll just ask you 3 questions, and in case any of the questions pop up on my screen from the audience, I'll be kind of asking you those as well. So my first thing would be, which are the major interstitial lung diseases? In case you have features of a cystic lung disease in a CT scan and you have features of interstitial lung disease, what are the most common diseases which will come to your mind as differentials, and what you would be kind of categorizing these patients as?
So in these cases, if we talk about the most common, we should always, if the background, that is, we are talking about a case where you have cyst and the background lung is abnormal, one of the things that you should always think about in the current scenario is hypersensitivity pneumonitis. So when we're talking about most common, that ways. But otherwise, the most common presentation when you talk about an interstitial lung disease, so lymphocytic interstitial pneumonia is the most common cystic interstitial lung disease, which presents with a background abnormal lung as well. So these two are the things that we should always keep in our mind when we see cysts in a background abnormal lung.
Yeah. And the next is, I know you've covered it again, how do you differentiate cysts from bronchiectasis or honeycombing that we see with IPF?
So one of the most important things that I would stress upon when we try to differentiate these is to always try and see the images on DICOM. When you try to do that and you scroll across, in bronchiectasis, things become very simple because you can, see that they are intercommunicating, moving towards the hila. Whenever these cystic areas are intercommunicating, they are not cysts. That's bronchiectasis. Then when we talk about honeycombing, they are sharing walls. So honeycomb cysts are always stacked, one over the other, one over the other. In cystic lung diseases, that stacking does not happen. So only when the cysts are all random, when you cannot, say that they are stacked upon each other, then they become cysts. So that's how we can differentiate honeycombing and bronchiectasis from a cystic lung disease.
Okay. And how do you differentiate DIP from LCH? Any specific radiological features that you look for?
So that's what something I even stressed upon, and I did give an example, a companion case on it. So it's, the first and foremost thing is that when we are talking about DIP, the dilemma happens because DIP is often associated with emphysema. So you have holes in the lung and you have GGO in the lung. So when you have holes in GGO, you are tempted to call it a cystic lung disease. The foremost important thing is that DIP with emphysema is not a cystic lung disease.
Yeah.
True cystic lung diseases have walls. So a smoker with holes can either have LCH or it can be emphysema with some DIP element. When it is LCH, they are well-defined cysts, the rounded cysts that stare towards you with walls around them. The emphysema cysts do not have walls. So often, there is some fibrosis around it which might mimic walls. But when you try to look at them properly, you'll realize that they're not true walls. They are not well-defined rounded cysts. And the moment you are able to differentiate that, life becomes simpler, and you can, that you are dealing with a DIP versus a PLCH.
Yeah. Thank you so much, Dr. Khushboo, and thanks for sharing the knowledge with us. And we are very grateful to you. I know you would not be,
it's completely my pleasure.
Stay on to the end of the conference, to the end of the seminar with us. So, very grateful to you for the time that you spent, and thank you so much. Thanks a lot.
Thank you. Thanks a lot. Thank you.
So now we move to the second part of our seminar, and I would be inviting Dr. Anitha Kumari for the next as the next speaker. She is a retired professor, pulmonary medicine, GMC Ernakulam and Trivandrum, former chairman, State Task Force for Medical Colleges, NTEP Kerala, former chairman of PMDT Kerala, former president, TAP CCM, and awards and achievement, Best Doctor Contributing to Tuberculosis Care in 2009 and APCC Innovation Award in 2016. And she has about 35 publications and books and chapters to her credit. So without wasting too much time and without holding her from enlightening us as far as cystic ILDs is concerned, I pass on the baton to Dr. Anitha Kumari K for her talk, and very warm welcome to you, ma'am.
Thank you, sir. At the outset, let me thank Dr. Amit for giving me this opportunity to talk on diffuse cystic lung diseases. Can I have the slides? I've entrusted. Yeah. Yes. Next slide, please. Next slide, please. Yes, so the cystic lung diseases, they include a group of diverse pulmonary disorders, and they're characterized by the presence of parenchymal cysts on respiratory imaging. Next one. Next one, please. So there is no universally accepted classification of the diffuse cystic lung disease, and this classification that came out in 2020 was based on the causes of cystic lung disease. So accordingly, you have the diseases associated with genetic mutations, under which you have LAM and Birt-Hogg-Dube, and neoplastic conditions, under which we have pulmonary Langerhans cell histiocytosis. Then associated with lymphoproliferative disorders, we have LIP. Then, of course, there are conditions associated with infections, occupational and environmental conditions associated with interstitial lung disease, and conditions that mimic cystic lung diseases. Next one, please. So we'll move on to, I'll be talking mostly about lymphangioliomyomatosis, LCH, Birt-Hogg-Dube disease, and LIP. And LAM is a rare systemic neoplastic disease associated with cystic lung destruction, chylous fluid accumulation, and abdominal tumors like angiomyolipomas and lymphangioliomyomas. And in LAM, you have two types. One is the LAM that is associated with tuberous sclerosis, and the other one is a sporadic LAM. So we have mutations in the two genes, TSC1 and TSC2 in TSC LAM, whereas in sporadic LAM, there is only TSC2 gene mutation. And these mutations are seen in all the cell lineages in TSC LAM, and therefore there is a vertical transmission. Whereas in sporadic LAM, this mutation is seen only in the neoplastic tissues which are present in the lung, lymph nodes, and the kidneys. Next one, please. So the basic pathogenesis is that because these TSC genes, they encode for two proteins, namely tuberin and harmatin. And these two together form a heterodimeric protein complex, that is the tuberin-harmatin complex, which is responsible for cell growth and survival. And because there is a defect in the genes, there is loss of tuberin-harmatin complex. And in addition, there is upregulated activation of the mTOR pathway, which results in disturbances in cell growth, motility, and survival, with increased protein translation, cellular proliferation, migration, and invasion. And in addition, the LAM cells, they express the lymphangiogenic VGFD, and also imbalances in matrix metalloproteases also implicated. Next one, please. So you see that there are foci of smooth muscle cell infiltration of the lung parenchyma, blood vessels, lymphatics, and in addition to that, there are cystic changes with expansion of the interstitium. And the LAM cells are positive for actin, vimentin, desmentin, and HMB45. Next one. Next one, please. So coming to the clinical features, 30% of women with LAM develop 30% of women with tuberous sclerosis develop LAM, and 10 to 15% of men with tuberous sclerosis develop LAM, whereas sporadic LAM is almost restricted to women. And the average age of diagnosis is 35 years. There are reports of prepubertal females having LAM, and also those above the age of 80 presenting with LAM. And usually they have progressive dyspnea, basically because of the diffuse cystic lung disease, and also because of sometimes associated effusions. They may present with pneumothorax. Then renal angiomyolipomas can be present, causing significant flank pain, hematuria, and rarely abdominal hemorrhage. And you can have the extrapulmonary manifestations like skin lesions, seizures, etc., if it is a TSC associated disease. Next one, please. Now, when to screen for LAM in an HRCT? When should you actually suspect it? So if you have a young or middle-aged non-smoking woman presenting with pneumothorax, or if somebody has already been diagnosed as tuberous sclerosis and they're asymptomatic, you have to screen after the age of 18, and after that every 5 to 10 years thereafter. Sometimes there is an incidental discovery of angiomyolipoma or lymphangiomyoma or chylous ascites and effusion, and then also you have to screen for LAM. And some of these patients just present with progressive dyspnea on exertion, which is unexplained, and therefore an HRCT should be taken. Next one, please. So, according to the ERS guidelines, diagnosis of LAM can be made with certainty. You have the HRCT showing the typical cysts, and you have other features like tuberous sclerosis, renal angiomyolipoma, cystic lymphangioliomyoma, or chylous pleural effusion or ascites. Next one, please. Next one, please. So it's nice to have a stepwise approach. So if the HRCT is suggestive, we have to ask about the personal history and family history of tuberous sclerosis, LAM, or even pneumothorax in the family. And a serum VEGFD testing, that is a level more than 800 pg per ml is diagnostic. Then abdominal screening is necessary for this renal tumors. And a transbronchial biopsy usually gives a yield of around 40%. If there is pleural effusion, lymph nodes or masses, you can do a cytological evaluation, and a VADS lung biopsy would be diagnostic. And FTG PET is important. Even though it is negative, it will help you to rule out other conditions like a lymphoma. Next one, please. Now, the American Thoracic Society, they have come out with guidelines for the diagnosis and management of LAM in 2016. Next one. Next slide, please. And according to them, when should you do VEGF estimation? So for patients whose CT scan shows cystic abnormalities characteristic of LAM, but who have no confirmatory clinical or extrapulmonary radiological features of LAM, ATS recommends VEGFD testing to establish the diagnosis of LAM before consideration of proceeding to diagnostic lung biopsy. So this comes with this is a strong recommendation based on moderate quality evidence. Next one. And coming to the treatment, associated angiomyolipomas, if they are present and they have a size more than 4 centimeters, they can bleed profusely. So embolization should be done, and there is a definite role for mTOR inhibitors like sirolimus. Then air travel is considered relatively safe, and bronchodilators should be given if the patient has reversible airway obstruction. And they present with pneumothorax, so pleurodesis should be considered in the first instance itself because there is a high chance of recurrence. And lung transplantation is the last option. Next one, please. So what is the efficacy and safety of sirolimus in LAM? This is a study which came in the New England Journal of Medicine. That's an old study. Next one, please. Next slide, please. So this is a 12-month randomized double-blind comparison of sirolimus with placebo, and the primary and followed by a 12-month observation period. Next one, please. Next one. So as compared with previous slide, please. As compared with placebo, the sirolimus group had improvement from baseline in measures of forced vital capacity, functional residual capacity, serum vascular endothelial growth factor, and quality of life and functional performance. Next one, please. Next one. So it was concluded that in patients with LAM, sirolimus stabilized lung function, reduced VAG3 levels, and was associated with a reduction in symptoms and improvement and quality of life. So sirolimus may be useful in selected patients with LAM. That is the conclusion. Next one. So what is the ATS recommendation for the use of sirolimus? So in patients with LAM with abnormal or declining lung function, ATS recommends treatment with sirolimus rather than observation. This is a strong recommendation. And for patients with symptomatic chylous fluid accumulations, we suggest treatment with sirolimus before invasive management. This is a conditional recommendation. Next one. And there are other potential therapeutic targets, including autophagy inhibitors, MMP inhibitors, aromatase inhibitors, cyclooxygenase inhibitors, and tyrosine kinase inhibitors. And finally, lung transplantation is an effective option for patients with advanced conditions. Next one. Now we move on to pulmonary Langerhans cell histiocytosis. This is a rare neoplastic disorder of unknown etiology characterized by the infiltration of the lungs by bone marrow derived Langerhans cells with an accompanying strong inflammatory response. Next one. Next slide, please. Now, based on the international consensus recommendation in 2022, LCH is classified as unifocal, single system pulmonary, single system multifocal, and multisystem. Next one. So, pulmonary Langerhans cell histiocytosis, this can occur as part of multi-system LCH or single system PLCH, and initially this is thought to be just an inflammatory reactive disorder, that is smoking induced disorder, but recent studies have shown that there are alterations in the MAPK pathway that is seen in 85% of the lesions, and the BRAF mutations are seen in 36 to 50% of cases, and therefore now PLCH is considered as a cigarette smoke induced or promoted dendritic cell neoplasm associated with a prominent immune or inflammatory component. Next one. Now the main changes are seen at the end of the small airways. That is, there is a peribronchial accumulation of the Langerhans and other immune cells, and there is destruction of the distal bronchial walls. So cigarette smoke can actually mediate the accumulation of these cells, and through the induction of cytokines like GMCF and TGF beta, and this is followed by granuloma formation, and granulomas precede airway remodeling and cystic changes. So later on, you see lesions with patchy cellularity, the stellate scar formation can be seen, and there is increased fibrosis. Next one. Next. So here you can see the Langerhans cells having pale eosinophilic cytoplasm with indistinct cell borders, grooved nuclei, and inconspicuous nucleoli. Next one. Now the clinical features usually seen in young adult smokers with no sex predilection. They usually present with cough and dyspnea on exertion, and spontaneous pneumothorax is common. They can have systemic features like asthenia, fever, weight loss. Sometimes they're just routinely picked up on a chest radiograph. And very rarely extrathoracic manifestations like lytic bone lesions, or if there is a pituitary stalk involvement, patient can have diabetes insipidus. And pulmonary hypertension is seen in 10%, and this can be because of involvement of the pulmonary vasculature. Next one. Now coming to the investigations for PLCH, the X-ray can show the nodular or cystic lesions sparing the CP angles. HRCT has already been described. And an FDG PET is important for evaluation of multi-system LCH. In fact, you have to do a head-to-foot skeletal radiographic survey, including a dental panoramic radiograph for looking for bone lesions. Next one. Now, lung function, in early stages it may be normal, and later there is typically a reduction in the forced vital capacity, and there can be evidence of air trapping with increased or normal RV by TLC ratio. And in advanced diseases, obstructive dysfunction is seen. DLCO reduction usually reflects a pulmonary vascular dysfunction. That is, there can be a disproportionate decrease in DLC if the pulmonary vasculature is primarily involved. Next one. And coming to the diagnosis, a transbronchial biopsy will give only a yield of 15 to 40%. So it's better to go for a VATS biopsy and take biopsies from the nodular areas that are evident on an HRCT. And the histopathology shows clusters of intermediate cells with reniform nuclei, nuclear grooves, and all this in the background of inflammation. And the changes are mainly in the distal bronchioles with destruction of the walls. And if you want to do an IHC to make the diagnosis, you go for a minimal panel of CD1A and Langerin or CD207. And for BRAF mutation, can be identified by IHC using a mutant-specific antibody clone, namely VE1. Next one. So these are the characteristic IHC phenotypes that you see. So CD868 is positive, cyclin D1 is positive, S100 is positive, but most important ones are CD1A and CD207 bar Langerin. Next one. Now treatment is smoking cessation, which can cause significant resolution of lesions in most patients. And inhaled corticosteroid with LABA is indicated in those with wheeze and airway obstruction. And, the patient, if he presents with a pneumothorax, surgical drainage of the pneumothorax should be done, and fluorodesis should be done because of the chance of recurrence. And systemic therapy should be given for those with worsening symptoms in spite of smoking cessations. Next one. So the treatment of choice is cladribine, that is purine analog, and this is associated with improved lung function. So in patients where the symptoms persist or there is a rapid decline in the lung function, cladribine can be used if there is no response with smoking cessation. Cytarabine and clofarabine are used as salvage therapy, and now we have newer drugs coming up like the BRAF inhibitors and the MEK inhibitors. And lung transplantation is indicated in advanced pulmonary Langerhans cell histiocytosis, but relapse in transplanted lungs can occur, and the 5-year survival is around 50%. Next one. Now we go to a more rare disease, Birt-Hogg-Dube syndrome. It's a rare autosomal dominant disorder characterized by the development of hair follicle tumors, renal neoplasms, and pulmonary cysts. And all this occurs because of germline mutation in the FLCN gene, which actually encodes for the protein folliculin. Next one. So it can affect males and females equally, and the lesions are seen in the 4th to 5th decade. There may be a family history of pneumothorax or renal cancers. The most common presentation is a pneumothorax with high recurrence rate, and the skin may show fibrofolliculomas or trichodiscomas. Skin tags or acrochordae may be seen over the head, neck, and upper trunk. There's a 7-fold increase in renal cancer in Birt-Hogg-Dube syndrome, and also a significant increase in colorectal cancer. Next one, please. So here the pathogenesis is because of the FLCN mutations causing again dysregulation in the mTOR signaling. Other pathways implicated are the TGF-beta and the DEN, that is differentially expressed in normal sense and neoplasia. So because of the activation of mTOR, there is adhesion protein defects, and that causes an increased vulnerability of the alveolar septal junction to tearing forces during the respiratory cycle and subsequent cyst formation. Next one. So you see histopathology may show cysts abutting the interlobular septa, and most of the cysts are not communicating with the airways, and there is no evidence of neoplastic cell proliferation or inflammation. Next one. HRCT will show the typical lesions, lentiform, thin-walled cysts of varying size, and they are usually predominantly basilar or subpleural, and there are skin lesions. Sponge biopsies are advised. Screening for renal tumors should be done, preferably by an MRI. And if the initial screening is negative, repeat the screening after 3 years. And PFT shows preserved spirometric values with mild reduction in DLCO. And genetic testing for FLCN mutation will confirm the diagnosis. Next one. So treatment for early surgical fluorodesis is advised even after the first pneumothorax, and avoid diving, travel to high altitude, and avoid smoking. There is no specific treatment currently available. Next one. So next is LIP. This is a clinicopathological term that describes diffuse involvement of the lump parenchyma by reactive pulmonary lymphoid tissue, often with follicular bronchiolitis. So this can be idiopathic or associated with connective tissue diseases like Sjogren's, rheumatoid arthritis or SLE, or associated with immune suppression. Next one, please. And here there is lymphocytic infiltration and cellular expansion of the interstitium with fibrosis. And how do the cysts occur? That is occurs because of ischemia from vascular obstruction, or it can be a post-obstructive bronchiolar ectasia. Next one. So there is dense interstitial infiltrates, and these are made up of small lymphocytes and plasma cells. And sometimes you find reactive germinal centers in up to 50% of patients with idiopathic LIP and CTD LIP, but it's not seen in HIV. And occasionally, non-necrotizing granulomas may be seen. Next one. So diagnosis is basically made based on the ground glass appearance, centrilobular nodules and cystic changes, with PFT showing a restrictive physiology and reduced DLCO. Transbronchial biopsy can give a low yield, and surgical biopsy may be needed for a definite diagnosis. Next one. There are no randomized controlled trials for the management of LIPs. Usually they are treated with oral prednisone 0.25 to 0.5 milligram per kg for 8 to 12 weeks. And then the patient is re-evaluated symptom-wise and physiologically. And if there is an improvement or the patient is stable, then you can start tapering to 0.25 milligram per kg, and that is continued for another 6 to 12 weeks. 20% of the cases are refractive, and the immunosuppressive agents like azathioprine, cyclophosphamide or rituximab may have to be given. Next one. So this is just an attempt to compare the different diffuse cystic lung diseases. So the pathogenesis for each of them I've described, and look at the clinical features. So LAM occurs almost exclusively in women, whereas PLCH can occur in young smokers and seen in both sexes. Burthoff-Dube disease, the important history is that there can be a relative with Burthoff-Dube disease, or there can be a family history of pneumothorax, and the skin lesions and renal cancer. All these may give you the clue. Whereas in LIP, it is usually associated with autoimmune conditions or immunological conditions like Sjogren's syndrome or HIV. Then the characteristic features of the cyst that has all been described. Then other findings in HRCT, that is important. For LAM, you can see associated chylous pleural effusions. PLCH, you see the nodules as well. Burthoff, there are no associated features, and LIP, you see ground glass opacities, poorly defined centrilobular nodules, interlobular septal thickening is also present. Next one. And extrapulmonary manifestations for LAM, you have to look out for renal angiomyolipoma, chylous effusions, lymphangioliomyomas, and other TSC lesions. In PLCH is generally associated, is generally isolated, but rarely you see lytic lesions in the bone. And pituitary stalk, if it is involved, patient can have diabetes insipidus. Burthoff-Dube is associated with skin fibrofolliculomas and renal tumors, and LIP. There are connective tissue disease symptoms like Zika symptoms or Raynaud's phenomenon. And supporting investigation, LAM, you go for VEGF estimation. For the PLCH, you can go for BRAF mutation testing. For Burthoff-Dube, genetic testing for FLCN mutations. And for LIP, autoimmune, that is a panel, HIV testing or VATS biopsy. Next slide. So this is an algorithmic approach to the diagnosis. So once you have a diffuse cystic disease on the chest CT, you have to ask about the onset of symptoms, whether it's acute or associated with any constitutional symptoms. In that case, we have to think of infective etiologies. But if these are lacking and there's a chronic lesions, then you can look at the shape of the cyst. So the typical shapes we said, smooth round cysts, it would suggest LAM, lentiform or elliptical would suggest Burthoff-Dube, bizarre shaped PLCH, and round cysts of varying size associated with ground glass, think of LIP. And then you do the confirmatory tests which I have described, and then you can come to a safe diagnosis. Next one. So to conclude, a variety of pathophysiological processes can present as diffuse cystic lung diseases, and establishing a correct diagnosis is very important. And because in some of these conditions, at least, we may be using some medications which can cause side effects. And HRCT is a very important evaluation tool, and confirmation is done by tissue or genetic analysis. A better understanding of the pathophysiology would definitely lead to the development of targeted therapies which can improve the quality of life of these patients. Thank you.
Thank you, Dr. Anitha. I must say a wonderful and a very elaborate talk. In the first session today, we heard a radiologist speak about all the, CT nuances of going into the details of cystic lung diseases, how to differentiate one type of cyst bronchiectasis and all the other air-containing spaces in the lung parenchyma. And now we had a talk from a pulmonologist talking not only about the radiology, but the whole gamut of the disease, emphasizing the fact that history taking, as far as the patient is concerned, family history, systemic examination of the patient, looking at extrapulmonary manifestations of a particular disease in case we are looking into a complex of diseases or a syndromic disease. It is very, very important. Going through all the diagnostic algorithms, differentiating, trying to differentiate one from the other. And I must say, in the last, say, 10 odd years, we have made a certain headway as far as treatment of these conditions is also concerned. So as you can understand from the last two talks, today primarily we'll be focusing on LAM, BHD, PLCH, and LIP. And I have a very learned panel to kind of carry on this discussion forward. Some of the whatever questions I'm going to ask you are going to be repetition, but a couple of questions are going to be, popping up on the screen, and I would invite any of the panelists to kind of answer that. So just to take the session forward, I would like to invite 4 panelists. We have Dr. Sanjeev Mehta, Dr. Vishnu Sharma, Dr. Abhishek Tandon, and Dr. Suprova Chakraborty. My pleasure to introduce Dr. Sanjeev Mehta. Of course, sir needs no introduction, current affiliation. We all know he's associated with Lilavati Hospital, Arogyanidhi Hospital, Chest and Allergy Center, Mumbai, and professional positions held, of course, chest physician, Lilavati, Arogyanidhi Hospitals, founder chairman of Maharashtra chapter of ICS, founder of Lung India Foundation, founder of Mumbai Chest Group, recipient of Presidential Citation 2018 Chest in ACCP, recipient Dr. C.V. Ramakrishnan Oration, Indian Chest Society, P.S. Shankar Oration, Dr. K.C. Mohanty Annual Chess Conference, and NCCP India. Past Chair Council of Global Convened Governors, Chest ACCP, Abstract Reviewer for American College of Chest Physicians meetings, and multiple articles in books, papers, abstracts, lectures at national and international level, and a very avid, learned, soft-spoken, and a very elaborative speaker, I must say. Very, very warm welcome to Dr. Sanjeev Mehta, sir.
Thank you. That's very kind of you. Thank you.
Can I have the slide for the next panelist, please, on the screen? A very warm welcome again to Dr. Vishnu Sharma KM, who has been kind of a very learned professor. He's presently the head department of respiratory medicine, Indian Institute of Medical Sciences and Research Centre, Mangalore, founder secretary of Mangalore Chest Association, secretary ICS Karnataka State Chapter, and coordinator ICS National Talent Search. And of course, he has OA Sharma Oration in the 75th NatCon to his credit, Dr. A.B. Bhatt Oration, IMA Mangalore, APCCM Academy Oration in 2023, and more than about 100 publications to his credit. And he's well worthy of all the, awards and orations that he has received. And I welcome Dr. Vishnu Sharma M to the panel. Next, Dr. Vishnu, very warm welcome to you. We see you on the screen now. The next panelist for today's session will be Dr. Abhishek Tandon, a young and budding pulmonologist, presently an associate consultant, Department of Pulmonary Critical Care and Sleep Medicine, Vedanta, Lucknow, and keen areas of interest are asthma, ILD, and interventional pulmonology. Can I have Dr. Abhishek Tandon on the... Dr. Abhishek, are you there? Very, very warm welcome to you, Dr. Abhishek, and we look forward to a very healthy and fruitful discussion among all the panelists. The fourth panelist for today's session would be Dr. Suprova Chakraborty. She is a DNB in Respiratory Medicine, European Diploma in Adult Respiratory Medicine, She's certified in allergy, asthma, and immunotherapy. Presently, she's working as a consultant pulmonologist, Raj Hospital, Ranchi, and a consultant pulmonologist at Sadar Hospital, Ranchi, ex-senior resident, IPGMER, Kolkata, and member of ICS, ERS, CCI, and ATS, and participated as speakers in various national seminars and faculty for all the national conferences in the last couple of years. And I extend a warm welcome to Dr. Suprova Chakraborty. Can I have you on the screen, ma'am? Yeah, Dr.
Thank you so much, sir, for the kind introduction. Thank you so
Thank
much.
you. And I open the panel for discussion. I have a set of questions with me already, which I will be kind of, opening up for discussion one by one. In case any additions to be made, you are more than welcome to interrupt me anytime. And of course, as in how the questions pop up on my screen, I will be more than keen to take them on. Yeah, Dr. Sanjeev.
Can I have the pleasure of introducing Dr. Amit Dhamija? So can I please have his introductory slide? First of all,
Sir.
I mean, you need no introduction, Amit. You're very well known across the length and breadth of the country. And already for this program, you have enlightened us and conducted it so very well. I'm sure we are all looking forward to the rest of the discussions with you.
Thank you, sir.
That being said, Dr. Dhamija is a senior consultant in the Department of Chest Medicine at the Sir Gangaram Hospital in New Delhi. He is MD Pulmonary Medicine from the VP Chest Institute in Delhi, trained in critical care at Gangaram Hospital. He's trained in IP from the National Jewish Center at Denver, which many of you will know is one of the probably the #1 respiratory center in the world. So very well trained. He's done endobronch EBUS from Japan. He has multiple publications and presentations and book chapters. So a very avid learner and teacher. He's got major interest in IP, granulomatous lung diseases, connective tissue diseases, and lung cancer. He is the first to start the radial EBUS program and has the largest case series in India, and that's something to be really proud of. Second center in the country and the first in North to start linear EBUS, and recently started bronchoscopic thermal vapor ablation for COPD, which should be really, really interesting, and I'd love to hear about that. That being said, he's done a great job today, and we look forward to a very nice discussion under Amit's guidance. So I hand it back to you, Amit. And
Thank you, Dr. Mehta. And we would like to keep the audience engaged for the next 1 hour or so. That would be my job. And we'll try to keep the discussion as lively and interactive as possible, with a little bit of lighter note as well, dropping in from each of you. I guess we are all at the fag end of the day. We had a long working day. And of course, we would be waiting for the dinner at the end of it. So all of you must be hungry, but spare, some time, at least an hour, so that we can have a discussion on each and every question that kind of we have prepared for you guys. So let me begin with you, Dr. Sanjeev. What are cystic lung diseases? And, we all know, we have seen 2 lectures on that. The main concern, let's start with the basics. How would you differentiate between a cyst, a cavity, and a bulla?
Thank you. I think that's a very important question. When we see holes in the lung, that's a very, very basic question. Can I take the liberty to share a few slides? And I will
welcome. So that will make it very, very, informative for all of us rather than.
Thank you.
Yeah.
I'm not going to go into all the details, but I'm honored actually that the first speaker really presented these slides, which were taken from the manuscript, which I was co-author with Dr. Suhail and Nishant a couple of years ago. So this was our manuscript, and we wrote about an algorithmic approach to cystic lung disease. What I'm going to do in the next 3 slides is talk about the questions that you asked, and then I'll go on to just in the last 2 minutes give an algorithmic approach. So I'm one of those little authors in the bottom. But okay. So for those, and this is a bit of a repetition, but Dr. Amita Nene had said it's good to repeat for those who came later. So The basics of a cyst is that it is thin walled. I think that's primary. In my opinion, size and shape can change depending on the physiology and the various aspects of a patient's lung. For example, surgical, post-surgical, other complications. But a cyst is basically thin walled. It's well circumscribed lesion of low attenuation. It has to be surrounded by lung parenchyma as per the Fleischner Society. Now, it includes many things. I'm going to walk you through that. But before you do, and this is a cyst which is showing you the classic feature of thin wall, right? So there's a thin wall, multiple cysts, and this will classically fit into a cystic lung disease. Now, before we call this a cyst, we are going to ask ourselves the very question that you asked me: is it a cyst or is it something else? So I know that Dr. Khushboo alluded to this. Well, if this is a cyst which is looking a little disformed, then you must look at various reconstructions, and such as in this, and you will see, and she rightly said, it connects to one another. So this is not a true cyst, this is bronchiectasis. Then, to the other thing that mimics cysts is the presence of emphysema. What happens with emphysema is it has no walls, usually seen in the upper lobe, but you will identify a vessel in the center. I don't know if my arrow can be seen, but this is classic emphysema. You can see areas of low lung attenuation. You cannot identify a cyst going around it, and the bronchovascular bundle is somewhere floating free inside this. That is a very important hallmark of emphysema versus this, which is a cyst, which is well defined. It has a thin wall, and you'll see the bronchovascular bundle is outside the cyst. Once we're able to identify that, I think it becomes easy for the most part. Now, it's very easy for us to give lectures like this, but when you see a difficult case in your OPD tomorrow, you'll say, "Arey, Dr. Mehta ne ye to nahi bataya tha." But the point really is, if you stick to your basics and you see there is no wall in a smoking individual with the vessel in the center or on the side, you will be able to separate an emphysema from a cyst without too much difficulty. What we need to, and that is a question you asked, is a cavity. So a cavity really is a thicker wall. I think that's the first part of defining a cavity. It is thicker wall. The diameter is usually of the wall is more than 4 millimeters, and a cavity typically is an area of breakdown. Whereas a cyst is an area of breakdown of lung, a cavity is usually a breakdown of pathology. So it is seen inside a pulmonary consolidation, it is seen inside a mass lesion or a nodule. Once we do that, then we know that this is not a true cyst. And if you stick to the 2 millimeter and 1 millimeter definition of cyst wall, and you will not make a mistake with the cavity. I think those are the 2-3 things you wanted to ask. And then, of course, bulle. Well, one of the things that our article spoke to, that really bulle are a kind of a cyst. And these are subpleural cysts, and sometimes they can be big. They can go as much as 1/3 of the lung or even bigger and compress other parts of the lung. Bulle are usually not diffuse, like say diffuse cystic lung disease. And so therefore, bulle are thin-walled. They could be less numbers. They can be large. But please be clear that you deal with the bulle, because I've seen people mistake a bulla for a pneumothorax, put a tube, and they're stuck forever because now they get a bronchopleural fistula. So please be careful when you deal with the bulla. Now I'm going to get over. So this is a paraseptal emphysema. This is a bulla. Often you will see that it doesn't have. It is a cyst, so you can see, but it is an outgrowing of emphysema really, and so therefore it's more often seen on one side, but it can be seen anywhere in the body. And of course, these are honeycomb cysts, as was spoken to earlier, the multiple. Now, what I'm going to do is take you right to my last slide, and maybe we'll share some of these later. So this is the algorithmic approach that Sohail and our team put up. When you look at a cyst, the first question we will ask is, are these true cysts? And I know I'm repeating a lot of what was previously spoken, but this is our algorithm. So I hope you can bear with me for just 1 minute more. So are these cysts? We say no. And then that means I just told you cavities, centrilobular emphysema, panlobular emphysema, and cystic bronchiectasis. They are not true cysts. If they are true cysts, then the question is, are they intraparenchymal or are they subpleural? If they are subpleural, they will be bullae, paraseptal emphysema, honeycombing. If they are intraparenchymal, then are they single cysts without other are they cysts without HRCT findings, in which case they would be incidental pneumatoceles or bronchogenic cysts, or they are multifocal and the surrounding parenchyma is normal, which is the Burton-Dubé, the tracheobronchial papillomatosis, LIP, malignancy, infections, LAM, and PLCH. I'll rush through this because this has been covered. But if they're associated with nodules, then it is LIP, amyloid, PLCH. And if they are associated with ground glass opacities, then they are pneumocystic Zherokovae and DIP disease. So those were some of my thoughts. I hope I've been able to address the questions that you asked. And sorry for taking the time. Amit, you're muted. Sorry.
I said good that you had some pictures to show that made things really, really clear for all of us. Coming down to the next question, this would be for you, Dr. Vishnu. What are the various cystic ILDs that we commonly encounter in our country? And
there is a subtle difference between cystic ILDs and cystic lung disease.
Yeah.
Cystic lung disease means in between the cysts, the intervening lung parenchyma is normal.
Absolutely.
Whereas in cystic ILDs, the intervening lung parenchyma has got disease, interstitial lung disease. So the major, most important cystic lung diseases include LIP, diffuse interstitial pneumonitis, amyloidosis, and hypersensitivity pneumonitis. Over to you.
And we all know that ILDs are associated with a restrictive and a diffusion defect on pulmonary function test. How do the pulmonary function tests in cystic ILDs differ as compared to other, say, fibrotic ILDs?
Yeah, the hallmark of ILD is a reduction in the lung volume, which is not so in cystic lung disease. There is no reduction in the lung volume. Rather, in some cystic lung disease, the lung volume may be increased, especially in PLCH and so on. Secondly, if you do a spirometry in ILD, we get a restrictive lung disease, whereas in cystic lung diseases, it may be a mixed pattern, obstruction and restriction. And cystic lung diseases are basically diagnosed with a HRCT. The other pulmonary function tests, especially DLCO and other things, may not be of much use for a follow-up of a cystic lung disease. HRCT is a main for a follow-up of a cystic lung disease to know the progression of the disease. The routine spirometry and DLCO is of not much use for a regular follow-up. HRCT is essential.
Yeah. Thank you so much, Dr. Vishnu. And I must say that in case you have an obstructive or a mixed pattern and a cystic ILD, then that kind of completes the picture as far as diagnosis is concerned. Coming to you, Dr. Abhishek, what is LAM and what is the pathophysiology? How does LAM develop?
Thank you so much for the question, Dr. Dhamija. So basically, LAM or lymphangiomyomatosis, it's a fine line between malignancy at one spectrum and interstitial lung disease at the other. It's basically the proliferation of smooth muscle-like cells, which are called the LAM cells. When they proliferate, they exert their effects. When they proliferate and they cause an obstruction of the bronchioles, it causes air trapping. When they proliferate and they cause an obstruction of the lymphatics, they can result in a chylothorax or chylous ascites. Pathophysiological wise, there are various hypotheses we don't know for sure. There are certain reports which say that there's an imbalance between elastin and an anti-alpha-1 antitrypsin. There are certain case reports which says that there's an imbalance between metalloproteases and TIMPs. Hormones, especially estrogen, also play a role, but the later case reports are saying that the role of estrogen is somewhere dicey. So it's a group of disorders. The 2017 ATS guidelines classify them as an ILD, but the 2015 WHO guidelines classify it as a neoplasm. So I would put it between the two, a fine line dwindling there.
And going on with LAM, Dr. Suprova, what are the main clinical features and presentations you would expect in a patient with LAM, and how would your diagnostic approach as far as history taking and examination is concerned when you try to look for LAM in a particular patient or cystic lung disease who's come to you?
Yes, sir. Thank you for the question. Very good evening. Especially LAM have pulmonary and the extrapulmonary manifestations. If we come to the pulmonary symptoms, the most common is the exertional dyspnea, tiredness, and as if 56% cases present with spontaneous pneumothorax. So acute chest pain is very common along with when patient is coming with pneumothorax. Coming to other symptoms, pulmonary, we can see wheeze, which is mimic of asthma sometimes in 36% cases, especially when there are chylothorax. And cough is also sometimes presented, which are mainly dry in nature. And chylous pleural effusion is also common in LAM, especially in sporadic LAM. And we know as there is lung involvement, cystic, there is lymphatic involvement also. Because of the lymphatic involvement, there is chylothorax is very common, and there can be chylous ascites also, chyluria also, along lymphadenopathy also, and because of that obstruction, there can be some associated symptoms. Also, lymphangiomyoma and angiomyolipomas cause the obstruction. We can have a flank pain and hematuria or urinary retention with some patients. Especially LAM is sporadic and associated with tuberous sclerosis complex. If some cases are associated with this complex, then there are more extrapulmonary symptoms like hepatic involvement, renal involvement. There can be some skin involvement and also neurological involvement because of the nerve involvement there. So this is a huge pattern. So we have to see if female predisposition more with the sporadic one, and tuberous sclerosis complex is also found in male. So according to the other involvement, we have to proceed.
Very rightly pointed out. In fact, we should look at other systemic involvement whenever we see a patient of cystic lung disease, because most of these disorders will have some pointers elsewhere in the body, so that we are able to characterize and differentiate one from the other. So from the clinical features and presentation, I would come back again to you, Dr. Anitha, to kind of give us some more kind of detail about the radiological features of LAM and how kind of differentiate LAM as far as CT is concerned from other cystic ILDs or cystic lung diseases that we talked about. Dr. Anitha, you are muted. Yeah.
So in LAM, you see multiple small, smooth, round, thin wall cysts which are evenly distributed in both lungs with no zonal predilection, and the size usually is 2 millimeters to 2 centimeters. Associated pleural effusions may be present. The costophrenic angles are involved with sparing of the apical region, and the intervening lung is normal. Lung nodules are absent. So these are the features of LAM radiologically.
So most importantly, you'll have pleural involvement in LAM. You will have smooth cysts. There is no specific zonal variation, but the upper lobe sparing is definitely seen. And intervening lung will be normal as compared to nodules which you see in PLCH. So how would you, suppose you have a case, what will be the diagnostic algorithm, Dr. Mehta, as far as LAM is concerned?
Yeah, thanks. I think that's important. First of all, we have to have a very high level of, shall I say, sensitivity towards the diagnosis of LAM. So I think a very high level of awareness to suspect it. So in a younger individual lady, non-smoker, if she comes with increasing shortness of breath, an X-ray may or may look normal. A CT scan would be very helpful with the features that Dr. Anitha just mentioned. That is what sets you on the path towards a diagnosis. Now, there she has already given us features. Frankly, if you have a lady who's in childbearing age, has chylus pleural effusion, you really don't need to get to, there are not too many differentials for that kind of an individual. But that being said, if you really want to label it because it's a very difficult disease, then in earlier days, we used to say, do a lung biopsy, which will be, I mean, realistically speaking, it has to be an open lung biopsy, because if you do a transbronchial, the tissue is so tiny that you may not get enough tissue to even stain. Once you get the tissue, it is HMB45 positive, and that will help you to get the diagnosis from the biopsy. What to me is very encouraging is the latest guidelines that which say that if the VEGF-B number is more than 800 picograms per ml, then you do not need a histopathology. It is that diagnostic. And I think that has simplified things a lot. In the clinical context, with the sufficient radiology, if you get a very high VEGF-D, which is more than 800, I think you're pretty.
And how common do we find labs doing endothelial growth factor?
No, don't ask difficult.
It is kind of impossible. You kind of look through the all the list of tests available in various labs. In fact, I've had instances of this sent to Calcutta and then Chennai from Delhi, where we did not find any lab in the local vicinity. So anybody who's probably heard of VGFD being done.
I think they send it abroad. So you get a good lab like, I think, the new Mammoth lab.
Most of them would need to have a tie-up. I don't think they would be having enough number of samples to justify it being done as an isolated test here. But yes, of course, it is going to be a very, very difficult time looking for a lab who can do this test for you. But in case you do not, then make sure that you have all the requisite clinical, radiological and other extrapulmonary features to guide you as far as treatment is concerned. Lung biopsy transbronchial will give you a diagnosis only in about 40% because of the small tissue that you get in a TBLB. A surgical lung biopsy is definitely preferable, and you'll have a better control of the situation as far as managing any complication of a biopsy like bleeding or a pneumothorax is concerned. Thank you, Dr. Mehta. Thank you, Dr. Sanjeev. So now, LAM, again, we know that when we were studying, we really had no treatment. People used to, giving hormones, people had hysterectomies and, oophorectomies and various other things which were kind of practiced. But now with the identification of mTOR pathway being kind of responsible and kind of involved in this particular disease process, what is the role of sirolimus? Is it approved? And what is your experience, Dr. Vishnu, as far as treatment of LAM with sirolimus is concerned?
Yeah, so now it is proven beyond doubt that the hormone therapy has got no role.
Exactly.
In treatment of
when we were studying, it was primarily hormone therapy. So we really had no choice but to offer that to our patients.
Sirolimus is a relatively new drug which has been approved for the treatment of LAM. It is known to improve the outcome in LAM, especially the pleural effusion, that is the chylothorax, and also it is known to reduce the angiolipomas.
Angiomyolipomas. So the role of sirolimus is definitely proved, and we had a very good paper which talked about it, randomized control trial. So definitely the symptomatology of LAM, including the obstruction, the worsening of lung function, angiomyolipomas, the rate of any complication that we see in angiomyolipomas like bleeding or rupture, they will definitely be lesser in patients who are treated with sirolimus than patients who have been on any of these conventional or say traditional kind of therapies that we had done in the past for all these patients. But by far, we've had many of the questions being put up in the list. Many of the people are perplexed and they were not aware that sirolimus is now approved for LAM. It is in fact the drug of choice for LAM, and we must be, conversant with the use of these drugs. I know we would not diagnose LAM very, very commonly in our practice. We would see very few cases in our lifetime, but in case we do come across one, we should know what to do with that patient. So as far as treatment of LAMP is concerned, the medical management, the first drug of choice would be sirolimus. Of course, LAM is associated with complications like pneumothorax and chylothorax, and most of them would not really be easy to tackle, and it would be kind of a recurring problem for the patient. Dr. Abhishek, how would you tackle chylothorax, being kind of attributed to LAM in your practice?
That's a very important question, Dr. Dhamija. Like our professors used to tell us that historically, before the advent of the drug sirolimus, they used to do all sorts of things to manage chylus effusion in the patient of LAM, and it was mostly unsuccessful. Procedures like putting an ICD followed by a pleurodesis, procedures like ligation or an embolization of the thoracic duct, dietary modifications offering a low-fat, medium chain, high triglyceride diet. With the advent of sirolimus, things have drastically changed, and we have enough data now to support and say that even with a head-on comparison with each of these interventions which I've just listed, sirolimus has shown its superiority by leaps and bounds. So the go-to drug, even for a chylus effusion, yes, it would take some time, 2 to 4 weeks, but would be sirolimus. An indwelling pleural catheter or a ICD followed by a pleurodesis would be for a symptomatic patient, like if a patient is having severe chest pain or dyspnea, we would go ahead with that, but the primary therapy would be a sirolimus.
So primarily treatment for LAM chylothorax would be medical till the time the patient, if the patient is very, very symptomatic in the intervening period. In case we want to intervene, we can put in an ICD, we can give them an intrapleural catheter, we can even manage it with pleurodesis, but the rates of failure without specific therapy are going to be high, and we should be very, prudent, very aptly counseling the patients as to what to expect from each particular treatment, whether it is medical or therapeutic aspiration, changes in the dietary profile of the patient. But each of them will have their limitations, and we should be telling and guiding our patients as to what to expect out of their illness, how it would progress over time, and what to expect from treatment that we have to offer. In the next couple of years, we might have new therapies coming in which would prove to be more beneficial for these patients. I hope so. And of course, till that time, we would have to contend by doing, aspirations and ICDs for immediate therapeutic relief and sirolimus for long-term treatment of patients with LAM. Chylothorax being kind of taken care of. Dr. Suprova, what are the other complications, most important complications of LAM, and what would be the most, difficult symptomatology or difficult questions that the patient would pose to you in case they are diagnosed with LAM?
Yes, definitely. Sometimes patient first time may present with complications. Among those, pneumothorax is the most common complication. Right. And the recurrence rate is also very high, nearly 75%. So one such patient comes with spontaneous pneumothorax and with HRCT thorax itself, the LAM diagnosis is suspected. It should not be waited for the second episode of pneumothorax. So pleurodesis is recommended after the initial ICD management. Either it's chemical pleurodesis, sometimes surgical also can be done like through the mechanical abrasions. And after this recurrent pneumothorax, the second problem come with the chylothorax or chylus ascites. Sometimes repeated tapping is required, and that can cause, as Dr. Abhishek was saying, that some dietary recommendations are given. Sometimes lymphopenia, weight loss happens with this repeated. Then if the now the therapies are there with the sirolimus, if the medical management finally fails, it goes for the peritoneal, pleuroperitoneal shunt or peritoneal venous shunt. That is the last resort of management. Sometimes with the due progression of the disease, with pneumothorax, we get respiratory failure patients, we become oxygen dependent. And ultimately, with oxygen therapy, they are advised for lung transplant. And in in some patients, when they are coming with the abdominal symptoms, especially with angiomyolipomas, especially renal angiomyolipomas, they have hematuria, flank pain, especially when the size have increased more than 4 centimeter of size of AML, but the studies shows that surgical excision is not encouraged, rather the embolization is encouraged. Exactly. Because there is a high chance of recurrence in these cases, but with the therapy and the embolization, there is good management is possible. Then again comes in, because it is female preponderance is there, especially in sporadic cases, pregnancy. Pregnancy is not contraindicated in patient of LAM, but patient should be counseled very well, because premature baby or premature death and very much abortions, spontaneous abortions cases are also very common, and patient's own symptom like exertional dyspneas and all can increase during the pregnancy. So should be well mild to moderate symptom patients well counseled, and moderate to severe symptomatic patients should be discouraged if pre-handed before planning they are coming to the clinics. And again, the last resort, of course, the lung transplantation we see when it is very severe.
Thank you. And of course, we would need, maybe bronchodilators to relieve obstructive airway symptoms. We would need oxygen in case patient goes on to develop a respiratory failure. So we need to have a very kind of holistic approach, and the patient will need definitely major lifestyle modifications as far as getting along with the disease as in how they progress. And the rate of progression can be variable. We had patients who would be coming to us walking, and 3 years time they would be on oxygen. Couple of them would be following up for 10 odd years without very minuscule change as far as their functional capacity or their deterioration in lung function is concerned. So each patient will behave differently. We really would not have many prognostic markers to kind of guide them as to how their disease is going to progress. So we need to be very, very cautious and as far as our approach of managing these the patients are concerned, and we need to have a multi-pronged kind of an approach as far as dealing. I think we've covered LAM in its entirety, starting from the clinical symptoms and radiology, diagnostic algorithm, and the treatment. Coming to the next important cystic ILD, we would go on to Langerhans cell histiocytosis. And Dr. Anitha, would you please elaborate on smoking-related cystic lung diseases for all of us, please? Including PLCH, of course.
Smoking related. Am I audible, sir?
Could you please be a little louder or increase the volume of your...
So the main smoking, yes. The main smoking related interstitial lung diseases are respiratory bronchiolitis associated ILDs and desquamative interstitial pneumonias or DIP. And LCH is actually, it is related to smoking, but now after the identification of the mutations in the MEPK pathway and the BRAF mutations, now it is considered as a cigarette smoke induced or promoted dendritic cell neoplasm associated with a prominent immunoinflammatory component. And regarding RBILD, there is a 95% association with smoking, and patients usually have chronic cough, dyspnea, and you can hear inspiratory crackles. And HRCT usually shows centrilobular nodules, ground glass opacities, and bronchial wall thickening with occasional cysts. And histopathology shows pigment-laden macrophages in the respiratory bronchioles and alveolar ducts and associated bronchial metaplesia. And there is a good response to corticosteroids in RBILD. And DIP is also associated with smoking in 60 to 90% of the cases with clinical features of cough, dyspnea. And HRCT shows ground glass opacities, that is the most common finding. And cysts occurs in 32 to 75% of the cases. On histopathology, you will see diffuse alveolar filling with pigment-laden macrophages, and there is a response to corticosteroids is modest or variable. Okay.
So your mic is on mute, sir.
The difference in the pathogenesis and the management, of course, will depend on what we are diagnosing. I know it's again going to be a repetition, Dr. Sanjeev, but radiological features of LCH, and how do you differentiate LAM from LCH as far as the radiology on CT is concerned?
Sure. Can I quickly share one picture on the slide?
Most
Thank you. Thank you.
Pictures speak louder than words.
Thank you, Ji. Yeah. So I think, as you said, pictures do, and so here. So the question is LCH, and I think we've had a very good discussion on LAM, and the difference in LCH versus LAM is, in LAM you'll get thin walled. So first of all, the clinical context. LAM, non-smoker, more females, dominant can be seen across all lobes. But when we come specifically to the cysts, you can see that the cysts in LCH can be little diffusely bizarre. So some are, you can see here, whereas if you see this in LAM, they all look uniformly equal. Secondly, because it is seen in smokers, you'll see certain areas of emphysema. Now, micronodules are also seen in LCH, PLCH. So I think if you look at the overall picture, bizarre nodule in a younger individual who's male, who's a smoker, having these kind of variously shaped, you can see this cyst versus this cyst versus this cyst, slightly thicker walled, bizarre shaped cyst, and the presence of the emphysema and micronodules and interventional architectural distortion, which is a hallmark never seen in LAM. In LAM, the tissue itself is very healthy. I hope that makes it easier for us to differentiate between LAM and LCH.
LCH. Thank you, Dr. Sanjeev. And after radiology, what will be the diagnostic hallmarks of LCH? Dr. Vishnu, please. Dr. Vishnu? I guess Dr. Vishnu is taking a small break. Any of the other panelists would be keen to answer this question on his behalf. Diagnostic, Dr. Vishnu, welcome back. Dr. Vishnu, I was just trying to after Dr. Mehta talked about the radiological differences between LAM. We covered LAM in the first set of questions. Now we're talking about Langerhans cell histiocytosis. After finishing the radiology, how would you diagnose categorically? What would be the most important tests that you would order? And how would you differentiate LCH from all the other cystic lung disorders that we talked about?
Yeah, radiology plays an important role.
Yeah.
With the typical history of smoking and the upper lobe predominant, and some newer diagnostic tests which Dr. Anitha Kumari madam has already elaborated in her.
So of course you would have history, you would have radiology to kind of help you, and there are specific tests that you would order, and that would help you complete the picture of diagnosis as far as LCH is concerned. Dr. Abhishek, once you have diagnosed a patient of LCH, what would be the most important advice as far as treatment is concerned? And what are the most important factors that you look for as far as prognosticating these patients for their future life after diagnosis?
It's very important to emphasize the role of smoking cessation in a patient of LAM.
Absolutely. Absolutely. Undoubtedly, take home smoking cessation number one as far as treatment of LCH is concerned.
And as you correctly pointed out, for the treatment of LAMP, a holistic approach needs to be advised to the patient in the form of oxygen therapy, in the form of vaccination, in the form of pulmonary rehabilitation. But having said that, we also have a couple of medical management therapies that we can offer to our patients of LCH. Conventionally, we used to offer glucocorticoids upfront, agents like vinblastine, citarabine, and cladribine. And now with the advent of the MAPK pathway, we also have newer advances in the form of vemurafenib, dabrafenib, or a tramitinib. I've not used the MAPK pathway inhibitors in my clinical practice, but we did have a patient of LCH when I was doing my residency at AIIMS Jodhpur, and we were treating him with a combination of vinblastine and glucocorticoids. It failed, and we had put him on cladribine, and as of now, he's doing well on cladribine.
So rather than rather than LCH being an ILD, we know it is kind of an pre-malignant or malignant condition, and many, in case we are able to target MAPK pathway or BRAF, depending upon whatever the patient is positive for, in case we are able to give them specific therapy for that particular pathway to be inhibited, these patients definitely will have a better quality of life. The disease progression is going to slow down, and we are going to see less complications down the line as far as respiratory failures are concerned. In these patients, the most important thing would be to look at the respiratory parameters of the patient. Pneumothoraces again would be troubling, so we should do our best as far as managing complications are concerned. Doing kind of pleurodesis or any surgical pleurodesis, ICDs, whatever is there to make the patient's life a little more kind of better quality of life, as well as their respiratory support we need to be taken care of. And of course, specific therapies as and when available, in case they are positive for any of these pathways, we should be more than keen to offer, with of course the help of oncologists, because we're not very well versed ourselves with most of the therapies and all the side effects and complications that you ought to know before you prescribe. So make sure that you take help of oncologists and work as a team, taking care of the patient as a whole. So I think after completing LCH, we come to LIP. And I would be looking at Dr. Suprova to answer this question for me. LIP, will be associated with many systemic conditions or autoimmune or, genetic conditions. What is lymphocytic interstitial pneumonia? Tell us in brief. And what are the conditions that you would think of or associate LIP with if you see a patient?
Yes, sir. Lymphocytic interstitial pneumonia or LIP, it's a benign lymphoproliferative disorder, and it also comes into the cystic ILD disease, because in between the cyst, the interspace is also diseased, and it is because of the deposition of the lymphocytes, plasmacytes in interspace diffusely throughout the interstitium, alveoli, sometimes in vessels also. Mostly idiopathic LIP is very rare. It's mostly associated with other disorders, and it has a female preponderance. In female patients is mostly connective tissue disorder like Sjogren's syndrome. Sjogren's syndrome is the most common associated with LIP. It can be primary Sjogren or secondary, which is associated with another more connective tissue disorder like rheumatoid arthritis. SLE can also be associated with it. Apart from that, if it is a male patient or a young or maybe children, it's most commonly associated with HIV or common variable immune deficiency. Sometimes myasthenia gravis, primary biliary cirrhosis, and this kind of autoimmune disease are also associated with hypogammaglobulinemia, etc.
If you suspect a patient to have LIP as far as radiology goes, make sure you look at a couple of autoimmune conditions which can be associated with it. Look at autoimmune conditions as well as immunodeficiency states. So state of immunodeficiency and an altered immunity both would predispose a patient to have LIP like changes, and we should be kind of ordering all the possible tests so that we are able to label a patient as of LIP into one of these categories, and look at other manifestations, other extrapulmonary manifestations to categorize a patient as A, B, or C. Because in LIP, the treatment is primarily of the primary condition, and
Primary
that will
condition.
help us improve the lung problem as well. So in case it is SLE, we have to target treatment to SLE. In case it is RA, we have to look at RA. In case it is Sjogren's, the treatment is going to go towards Sjogren's, and that is what is going to improve the lung condition as well. And of course, HIV will make things very, very complicated. LIP with PCP and CMV and all the other opportunistic infections, it is going to be a very tough time for all the clinicians and even all of us to kind of differentiate one from the other. So make sure, in case you are looking at an immunodeficiency disorder and you are diagnosing LIP, make sure that you have kind of ruled out all the possible infective conditions which would mimic LIP, and after all the infective conditions have been kind of excluded by all the possible various means, whether clinical, blood test, or bronchoscopy, we should be labeling the patient as LIP and treating accordingly. Dr. Anitha, coming back to you again, what are the specific radiological features of LIP that you would look for in a CT scan?
So the HRCT will show diffuse or low predominant involvement with ground glass opacities, interlobular septal thickening, centrilobular nodules, and perivascular or subpleural cysts. So if there is a combination of small bronchovascular and subpleural cysts with widespread ground glassing, centrilobular nodules, that is suggestive of lymphocytic interstitial pneumonia.
And Dr. Sanjeev, what would be the diagnostic algorithm? What all tests would you order, and what sort of biopsy, in case any, would you suggest to diagnose or pinpoint pinpoint LIP in a patient?
Can I again share for the last time one slide?
Of course, more than welcome.
Thank you. I'll just so for those of our audience, this is what LIP looks like, and you can see here it really looks like nothing else. Thin-walled cysts, which are occupy a large part of the lung, and basilar, centrilobular. So the presence, as I told you in the initial algorithmic workup, if you see centrilobular nodules and you see these cysts with with or without GGOs, then this is most likely LIP. Okay, so what would be the diagnostic
workup?
So I think the diagnosis really, it depends on what are you suspecting, or if you're not suspecting, then it's going to be a wide range. First will be a full panel of connective tissue disorder tests, which will include, like if you did an ANA immunoblot, we'll do SSA, SSB, so that you rule out the Sjogren, you rule out all the other connective tissue disorders. So run the entire gamut. One would look for various, of course, HIV will be top of the line. We would also make sure that you did test for combined immune deficiency syndrome and all the other conditions that could give rise to this. And that would be your workup, I think.
Yeah. So look at all the connective tissue disorders and run a panel of tests to kind of differentiate one from the other, as well as look at autoimmunity. Don't only look at HIV, but make sure the patient is worked up as far as their IGs are concerned, because CVID again is a very important association with LIP, especially if you're looking at children. So, Dr. Vishnu, what are the specific treatments that you would offer for LIP to your patient, and how kind of effective are these treatments really?
Yeah, as I already told, the treatment of LIP basically depends upon the cause. If we can find out a specific cause, the treatment should be targeted towards the cause. There is no obvious cause, then the steroid is if steroid doesn't work, go for other immunosuppressants or immunomodulator drugs.
So as far as treatment is concerned, the starting treatment for LIP, in case you have ruled out immunodeficiency, will be corticosteroids. In case the patient fails on corticosteroids or has a recurrence, then you would have an option to add on any particular drug. In case it is SLE, then you would go for mycophenolate, azathioprine, rituximab or cyclophosphamide. If it is RA associated, then of course you would look for drugs which are specific for RA. In case it is Sjogren's, then again, of course, roll off steroids and mycophenolate and azathioprine in that descending order. And of course, most of these cases, methotrexate might be helpful in the primary disorder, but as far as pulmonologists are concerned, and once we have seen a lung condition develop in a patient with autoimmune disorder, we should be hesitant in introducing methotrexate because, differentiating methotrexate toxicity from worsening of the, primary condition, the lung condition that we are looking at would again be very, very difficult. And there are no diagnostic hallmarks which are going to differentiate one from the other. So the treatment of LIP will depend on the primary disorder which we can associate with LIP, but avoid using methotrexate as far as possible in these patients. Coming to the next set of cystic lung disorders, BHD syndrome. So what is BHD syndrome, Dr. Abhishek, and what is the classical triad that you look for in a patient suspected of BHD?
So Birt-Hogg-Dubé syndrome is actually an autosomal dominant disease, which basically affects the lungs in the form of a cystic lung disease, the kidneys in the form of a renal carcinoma, and the skin in the form of classical fibrofolliculomas. It's basically due to the mutations in the FCNL genes, which encodes the proteins folliculin, which are responsible for the pathophysiology of the disease. Having said that, just an anecdotal bit of history. The classical triad initially was skin lesions in the form of fibrofolliculomas, trichodiscomas, and acrocordons, and they were later ruled out to be the same spectrum of disease viewed via different sections in the lens, actually.
Yeah.
So this was the classical triad, and this is the clinical triad that we spoke about.
Very right. And when do you suspect, what are the specific things that make you suspect of all the other cystic lung disorders that we have talked about, that it is a BHD syndrome? And what is this most specific history that you would ask Dr. Suprova in case you are suspecting BHD?
Yes, sir. First of all, if for patient, if he had any history of spontaneous pneumothorax, then any of his first degree relative had the history of spontaneous pneumothorax, and also renal carcinoma, renal cell cancer history is there in family or not.
Yeah.
So in spontaneous pneumothorax history runs in family, it's a very big clue because it's an autosomal dominant disease. And the cutaneous manifestation sometimes, because it is not progressive, so patient may be completely asymptomatic because of the cyst, it is there in subpleural or paramediastinal area, the elliptical cysts are present. Sometimes they can be completely asymptomatic before any event of pneumothorax. So because of the cutaneous manifestation, as Dr. Abhishek said, sometimes it can be completely an incidental finding. So they may come from a derma clinic for the association. When dermatological manifestation is same in the family, it runs the similar way because of the folliculomas or the multiple skin tags, which are mostly in nose, neck, and forehead areas. That can be found. Again, the also if these two are there, the skin manifestation and the incidental lung finding, then they should be screened for early detection of renal cell carcinoma. So these are the main points to suspect.
So rather than the patient, the family history is very important. As far as family history is very important. You would have first degree, second degree relative because it's an autosomal disorder, and people would be coming up with various instances of pneumothorax in the family, and that's how you think about BHD in the first place. Very importantly, renal cell carcinoma as compared to any other cystic lung disorder, the association of renal cell carcinoma is definitely very, very high. And many of the patients will develop RCC, so there is a definitive role of follow-up of these patients with repeated ultrasounds as far as their kidneys are concerned to make sure that the earliest development of RCC is picked up and taken care of rather than, we kind of taken on our back foot when the disease presents to us late in the presentation. So most importantly, family history as far as BHD is concerned. and the association of BHD with RCC is so strong that the patient would have to be on lifetime, ultrasound scans to, screen for any RCC as compared to any other cystic lung disorder concern. As we have, Dr. Anitha, diagnostic, tests which are specific for, couple of ILDs now, couple of cystic diseases now coming up, what is the one test that you would order in case you want to diagnose a patient for a BHD syndrome?
Well, it should be a genetic testing for FLCN mutation. That would be the test by which we can diagnose Bartók tube disease.
Yeah. So as compared to other tests which are mostly kind of supportive or not available, the FSCN gene testing is available and it doesn't cost much. I think about 8 to 10,000. So it should not be very difficult for us to convince our patients to get this test done. In case you are able to pick up the mutation in FSCN gene, the diagnosis of BHD is practically certain. And of course, the other thing, which of course Dr. Suprova said most importantly, would be the family history. Dr. Sanjeev, any specific treatment we can offer to these patients of BHD syndrome?
So, can I answer that in two parts?
Yeah, of course.
And that is any specific treatment for any specific treatment and any specific management.
Management, yeah.
So, so you already emphasized that.
It is only management. Treatment, of course, we do not have much to offer.
Treatment, we don't have any treatment, real treatment specifically directed towards Bartók tube. Now let's come to management, because it's a genetic disorder which we can't really change. Hopefully one day there'll be gene therapy for it, but that's not anywhere on the horizon. I think it's too far away. But so therefore, let's go to management. Specific to the patient is one, as you have rightly pointed out in the previous talk, is that you got to screen these patients for various associated disorders and particularly renal cell carcinoma. So therefore, ultrasound and coordinating with the other colleagues like derma and kidney. So that kind of a thing is general management. The other part of management is if these folliculomas or these growths do become painful, then they can be surgically removed, giving a lot of relief to the patient. Third, whenever these cysts do become large, then they may undergo pneumothoraces, in which case surgical pleurodesis will happen. I am not aware of any series that have dealt with lung transplantation in such individuals. That roughly is a specific management, but very important is going to be the genetic approach and genetic counseling. As you, I think, very well stressed, ultimately all these patients are going to become chronic end-stage lung patients, in which case the entire gamut of pulmonary rehabilitation with vaccines, with oxygen, with rehabilitation, all that will come into play for this disease as with all the other conditions in the end stage. That's just roughly an overview of management in my opinion.
So thank you, Dr. Sanjeev. Mostly it is management, not treatment, because there's no specific treatment that we can offer to these patients, unfortunately. We have covered LAM, LCH, we've covered LIP, we've covered BHD, whatever we know of it, in fact, we have covered. So in the first few slides, Dr. Khushboo had elaborated and given us a very long list of all the infections, which can be associated with cystic lung diseases. So although not a part of the discussion, but just to take this discussion forward, Dr. Vishnu, if you see cysts in the lung, what will be the most common infections which would come to your mind as far as, as a differential which would cause cysts in the lung?
Yeah, most often it is a bacterial infection, especially the staph, Klebsiella, Streptococcus pneumoniae, and E. coli. Sometimes even non-bacterial organisms, especially Pneumocystis cerevisiae, but more so in grossly immunosuppressed patients like HIV, and then some parasitic infections and even some fungal infections also can cause cysts in the lung.
So most importantly, in case you're looking at staph, E. coli or Klebsiella, you would look at cavities rather than, cysts. In staph, you would have some nematoceles, which would be the differentiating or characterizing as far as staph infection is concerned. So cystic lung diseases primarily would be seen in PCP, that is most common that we commonly encounter in our day-to-day practice. Parasitic infections again, and a few fungal infections would ultimately be leading to lung cysts. So any destruction of the lung parenchyma because of any infection, at the same time, you would have other features in the surrounding lung parenchyma as far as other areas, whether you have nodules, whether you have GGOs, whether you have a consolidation, whether you have lymph nodulopathy, whether you have a pleural effusion, locculated fluid. So many things in toto will be able to differentiate, tell us whether this particular cyst is related to some infection or it has come to the picture de novo. Apart from infections and autoimmune disorders and genetic disorders and other things that we've talked about, what are the rare causes of cystic lung disease, and anything that you can kind of peculiarly pinpoint, Dr. Abhishek?
It's a very difficult question to answer because
I know fag end of the day, you must be tired, but
just to academically point out, I don't think many of us would even see this in our clinical practice on a day-to-day basis. But certain diseases like an amyloid or a light chain deposition cause a cyst. In the background of a mosaic attenuation, a hypersensitivity pneumonitis can also present as a cyst. Certain cancers in the form of a metastasis, especially from the head and neck, and renal cell carcinoma can present with cysts in the lungs. So on the top of my head, one more cause is a respiratory papillomatosis. So there are certain things which I can think of over the head. Very rare causes of cystic lung diseases which need to be kept very, very low in the differentials and ruled out just for the sake of it.
Apart from that, you can have some maybe sarcoidosis, rarely, sometimes, hypersensitivity pneumonitis, which would have associated features, but sometimes they would be presenting as cysts in the lung as well. Just to complete the list, this is going to be long, but these are the most common things that we would encounter in our clinical practice and which would be kind of difficult for us to come to a conclusion in case we see cysts. So there will be certain hallmarks of each and every disease which you'll be specifically looking for in a particular patient. And of course, we had a long list of questions for lung transplant popping up on the screen. We'll just come to that. Non-pharmacological treatment of cystic lung disease, Dr. Suprova. We've covered most of it, but just give us a brief outline of the non-pharmacological treatment development.
Yes, sir. It's mostly non-specific and especially disease-specific. Yeah. Because if it comes to PLCH, again, we should ask stop smoking by any means. Then again, if it is lamb and a female patient, we will ask to stop any OCPs if they are using at all. And if when the disease advances, and we know like cystic interstitial lung disease like LIP, always the associated cause being treated sufficiently. And after that, we always, in general, pulmonary rehab, there is a great role. And along with that, nutritional supports, specific nutritional supports like in lamb, chylothorax, we already discussed. It should be high protein, but low fat, but high triglyceride diet are recommended. And then airway clearance techniques, we have a lot of flutter devices, airway oscillatory devices. Then especially counseling, which things to avoid and what to expect from their life, it is very important. In advanced disease, to check the resting, the nocturnal SpO2, after the 6-minute walk test, monitor at home, the exercise tolerance daily, how it is to monitor the progression of the disease and to plan the diet and exercise accordingly. To avoid, if the young patient and especially VHD patient, we would tell not to do scuba diving, avoid high altitudes. And coming to the air travel, it is seen, it is controversial because air travel per se do not cause the high risk of pneumothorax, but patient should be explained if in case such scenario happens, what to do and which kind of symptoms they may face. Then again comes the oxygen supportive therapy. And if in case some other extra pulmonary symptoms are there, like in case of AML, which is causing a kidney involvement, obstruction, then the urologist will be, involved in the cases for embolization and all. So this is a more disease specific and day-to-day basis to improve the quality of life, whatever is necessary. And of course, the lung transplantation is there, the end of disease. severe disease.
Thank you, Dr. Suprova. I was just going through a list of questions that the audience has been asking us, and most of it has already been answered. And Dr. Sanjeev has been kind enough in his chats to give answers to a couple of them in between. I think there are two things which we need to discuss. One is lung transplant. Lung transplant we know is coming up in a big way as far as any end-stage lung disease is concerned. And so, rightly so, that it is important to talk about lung transplant in cystic lung diseases, how successful it is, and what the disease which the patient primarily has would affect the transplanted lung as well. A very important and pertinent question which would be crossing minds of all the people who are listening to this particular talk. And we have a couple of questions on that. Next, I would request any one of you to answer very important thing of pediatric, cystic lung disorders. I do not have much of an experience. I don't think we have any pediatric specialists amongst us, but in case any one of you could answer that, I would be keen to sum up the evening by answering a question on cystic lung disorders as far as children is concerned. Dr. Anitha, let's hear about lung transplant as far as cystic lung disorders is concerned.
So, lung transplantation is an option in patients with severe lung function impairment or moderate to severe pulmonary hypertension, and survival rates in LAM when transplantation has been done is comparable to other diseases. But there are reports of recurrence in the graft that has been reported, and the 5-year survival is 65% with improved quality of life. Similarly, lung transplantation has been an option for PLCH in patients with severe lung function impairment and pulmonary hypertension, and there are rare reports of recurrence of the disease in the allograft in PLCH also.
Thank you, Dr. Anitha. Anybody who would have had time to Google through pediatric, cystic lung disease, the time, Dr. Anitha, I expected it to take about 2 minutes more for us to kind of go through our phones, but unfortunately, you summed up in just 1 minute. Dr. Abhishek, yes, your take on that.
Causes of my head. One would be a bronchopulmonary blastoma, and the other one would be a congenital pulmonary alveolar malformation. So these are the two cystic causes that we commonly see in our pediatric age group.
Yeah, CPAM, of course, it would have a larger cyst, and it would be not typically the kind of cyst that we see. I've had instances of hypersensitivity pneumonitis, seen in a couple of children who would have somehow associated cyst, but apart from that, nothing else comes. Dr. Suprova, yes, please.
Yes, even follicular bronchiolitis, I think in pediatric patients is very common. Yeah. The early stage of lymphocytic interstitial pneumonia per se, it can progress, but we don't know the progresses, like how it progressed, because most of the time we could not follow up. Maybe the acute phase the patient came, and how it goes, we need a better opinion regarding that. This is a cystic ILD in pediatric population.
Thank you. Thank you so much. And I must say, 2 hours, went by like this. And we had a long discussion, a very fruitful discussion, and it was kind of very interesting to interact with people from all across the country. Great to share that we have had about 1,800 logins for this particular webinar. And I'm very happy to see us going through all the questions. In fact, all the questions which were going in the audience's mind, we had kind of practically covered most of them given the time frame that we had of 1 hour. Of course, we could have a longer discussion, but time permitting, I think all of us have done a wonderful job. I must congratulate and thank all of you once again personally, Dr. Mehta, Dr. Suprova, Dr. Anitha, Dr. Vishnu, Dr. Abhishek, and Dr. Khushboo, who could not have stayed on till the end of the session. And I'm grateful to ICS for giving us this opportunity, and I'm very thankful to the audience for being with us throughout the last 2 hours of the discussion. I hope it was worthwhile, and you've had instances and it would make you wiser as far as your daily practice is concerned, and that is the aim of these webinars. And good to hear from you. Any concluding remark from the
Amit, the team is only as good as a captain. We were led by a wonderful captain. You did a great job, steered the entire discussion. And I think the success, if any, is significantly because of you. So great job, and I look forward to being in another session with you at some point in time.
Thank you, Dr. Mehta, and I must thank Harshal from Cipla for being the backbone and coordinating with all of us for the last one day and giving us all the technical support for this particular meeting to take place. And with this, I conclude and take leave. And everybody, good night. See you again. Thank you.
Thanks,
Thank you.
everyone.
Thank you so much.
Thank you. Good
Thank
night.
you.
Good night.